Welcome, everyone. Thank you for joining the Chapman Colloquium MAP series. My name is Dr. Jochen Lennnerz from Massachusetts General Hospital, and I will serve as the moderator for today's session, which includes presentations by Dr. Geoff Oxnard and Dr. Leif Ellisen. Before we begin, I would like to start by thanking Novartis Pharmaceuticals, Regeneron Pharmaceuticals, and Sanofi Genzyme for providing educational grant support for this series. I also want to acknowledge Dr. Aditya Bardia, MAP Series co-chair, and Massachusetts General Hospital for collaborating with Dr. Chapner and STO on the development of this series. We are especially grateful to the presenters for their participation. Additionally, I encourage you to visit our exhibit hall, which you can access in the timeline on the main event page to learn more about each of our generous supporters. They include AstraZeneca, Foundation Medicine, Genentech, Novartis, Pfizer, and Takeda. They have posted informational brochures and videos for you to download and view at your discretion. In addition, you may set up a chat with a representative if you desire to do so. Information was emailed to attendees with details about how to receive continued educational credit for this event. CME credit is available only for the second presentation today. And now I'd like to introduce Dr. Oxnard presenting on genotyping techniques and reports, and Dr. Ellisen, who will discuss germline and ethical considerations. Briefly, immediately following the presentations, we will host a 15 to approximately 20-minute question and answer session. If you would like to submit a question to be addressed, please use the chat function of this platform to post your inquiry. Questions can be submitted anytime during the presentations. And please note that the microphone for all attendees are automatically muted, so you won't be able to speak. Without any further comments, let's proceed with today's session. Welcome again.
Thank you, Dr. Lennnerz, and welcome everyone. It's a pleasure to be addressing you here in part of the Molecular and Precision Medicine Chapman Colloquium. I'm Dr. Leif Ellisen, and I'm Program Director of Breast Medical Oncology and Director of Breast and Ovarian Cancer Genetics at Mass General Hospital. And today I'll be talking about germline assessment and the ethical, legal, and social implications. I have no disclosures relevant to this presentation. The learning objectives for the presentation today are to explain the limitations of somatic tumor testing for germline inference and the necessity for dedicated germline testing, to examine the best practices for informed consent concerning somatic and germline testing, and to discover familial issues driving reluctance of certain patients to undergo somatic or germline testing. To start off with, I wanted to be sure we were all on the same page regarding somatic versus germline cancer pathogenesis. At the top row, you see somatic cancer pathogenesis, which is most cancers. Namely, you have damaged chromosomes, mutations that occur in somatic cells and not germ cells. This could be biallelic inactivation of a tumor suppressor or monoallelic activation of an oncogene. In contrast, in hereditary cancer, we're dealing almost exclusively with tumor suppressors. And in this case, a single damaged or mutant copy of the gene is inherited through the germline in all cells, and cancer pathogenesis occurs when you have a biallelic inactivation. Now, because I'm a breast cancer specialist, many of the examples I'll be giving today are in the world of breast cancer, but you'll see why this is really relevant to all the issues that touch on germline testing. And among the most important is that most cancers are not associated with identifiable germline causes. In breast cancer, it's estimated that perhaps 15 or as many as 20% of breast cancers are due to hereditary causes, but perhaps 80% to only somatic pathogenesis. And then even among that minority that are due to germline causes, you can see listed the genes that are thought to be responsible as single genes for increasing breast cancer risk. And collectively, all the individual genes that we know to be associated with increased breast cancer risk only add up to slightly more than 20% of all hereditary breast cancers, which I said is a minority of all breast cancers. And one of the reasons why this is the case is that genes in the population whose mutation gives a high risk of cancer, in this chart, a high risk of breast cancer, are uncommon in the population. So you can see at the left genes that have high risk associated with them when they're mutated, such as TP53, BRCA1 and 2, are uncommon in the population. In the middle, genes that are associated with moderate risk of breast cancer, 2 or more fold increased risk, can be more common. And then the most common are individual risk alleles who individually do not confer significant increased risk, but collectively can result in increased risk. And these can be quite common, but currently are not generally used clinically. Now, we've heard previously about the important field of somatic tumor testing and the ability of somatic tumor testing to potentially identify germline variants for cancer risk. So the question comes up, of course, do we actually need dedicated germline testing? These are some of the reasons why the answer is yes. It turns out that the indications for germline and somatic testing differ for certain cancer patients. Secondly, many non-cancer patients have strong indications for germline testing. And thirdly, somatic tests are imperfect for the assessment of germline variants. And what do I mean by that? Well, one recent paper has quantified this imprecision in somatic tumor testing for germline variants. Lincoln et al. Reported that out of over 2,000 patients who underwent germline testing after somatic tumor testing, more than 8% of pathogenic germline mutations were not identified by the somatic test. And this was for a variety of reasons, including the fact that the gene was not on the somatic tumor test panel, that there were technical reasons, mutations such as intronic mutations sometimes are not detectable in the somatic tumor panels, and finally, variant interpretation differences between the panels. So yes, indeed, we need dedicated germline testing. So let's now talk about things relevant to the informed consent process for genetic testing, the complexities associated with genetic testing, and the way we think about decisions regarding which genes to test for and what the implications might be for patients. And again, I've chosen here a breast cancer genetic testing example. So you see on the right, the columns represent different multi-gene panels which may be available for patients with a suspected hereditary risk of breast cancer. And you can see, of course, that there are different groups of mutations, each with different significance. So let's go one by one from left to right regarding the different potential genes that could be tested. First, on the left, you'll see in yellow, BRCA1 and 2. And these, in addition to recommendations regarding cancer prevention, are used to assign the clinical prescription by the FDA label for specialized inhibitors called PARP inhibitors. It turns out that beyond BRCA1 and 2, there are a series of more than half a dozen genes which are associated with relatively high risk of breast cancer, such that a patient found with such a mutation might consider breast surgical prophylaxis, that is bilateral mastectomy, to prevent breast cancers as one potential option. Beyond these high-risk genes, there are even larger multi-gene panels shown here in yellow of 12 or more genes clearly associated with substantial increase in breast cancer risk that may mandate increased screening for breast cancer. And then finally, in the setting of mixed cancer histories, breast and ovary cancer, or breast and other cancers, there are additional options for even larger panels, namely incorporating the Lynch genes, hereditary non-polyposis coli, for ovarian cancer risk because of that association, or for patients with even more mixed cancer history, comprehensive cancer panels, which range between 30 and 80 genes. Currently, for simplicity's sake, the majority of patients who undergo germline testing undergo a multi-gene panel of 20 or more genes, which incorporate risk related to breast, ovary, Lynch syndrome, and all of these possibilities need to be discussed as part of the informed consent process. Now, let's talk about interpreting test results, how providers are getting reports, what they say, and what it means for patients. Because in the non-genetic expert community, this can be a source of confusion, both for providers and patients. So strictly speaking, there are 5 categories of mutations, aside 5 categories of variants. The top 2, deleterious or suspected deleterious, are the ones that are known to have data that alter management, that are associated often with increased or altered risk. The other 3 categories are either polymorphism, favor polymorphism, or variants of unknown significance. Now, variants of unknown significance are of particular relevance because of the level of confusion they can create. The prevalence of these variants of unknown significance, which are unknown significance simply because often of a lack of data or mixed data for whether they are really clinically meaningful. The more genes that one puts on a panel, the more likely one is to find a variant of unknown significance for any given gene. Sometimes we find as many as 2, 5, 10 variants of unknown significance in a single multi-gene panel tests. It turns out that reporting these variants is somewhat controversial because they are likely in the end to be benign, and generally they should not be used to influence management decisions, definitely not to influence management decisions by themselves in the absence of considering the family history. And the reason this is the case was pointed out here in a recent retrospective study of over 1,400 variants of unknown significance, demonstrated that the chance of these ultimately being reclassified to a suspected or deleterious mutation was less than 2% for any given VUS. And this is why reporting them has become somewhat controversial, and they generally should not be used to influence management decisions. Now, furthermore, if we test a patient, for example, because of breast cancer risk, there are implications beyond breast cancer. And this table simply lists some of those. So on the left column, you see genes associated with breast cancer risk. The next column over shows the risk of invasive breast cancer to age 70 for those patients. But then the third column shows the risks of other cancers. For example, ATM, germline heterozygous mutation, often is an indication for increased breast cancer screening, but has a variable association with pancreas cancer risk. And we know that exactly how to screen or prevent pancreas cancers is not well established, not necessarily the topic of specific actionable guidelines at this time. So knowing there might be increased risk, but not certain about what to do about it, is an area that can create concern for both patients and providers. And you can go down the list, CHEK2 for colon cancer, PALB2 for pancreas cancer and ovary cancer, potentially statistically significant increases of risk for other cancers, which, however, on an absolute level are small, and there may not be guidelines, again, adding further to the complexity of germline testing and the potential implications that both patients and providers need to be aware of. There are also possible increased risk for other genes which we don't test for necessarily for breast cancer risk. For ovarian cancer risk, we test for BRIP1, RAD51, and other genes, including Lynch genes, but may have a variable association with breast cancer risk. So with all this information in mind, let's then discuss and cover the elements of proper informed consent for genetic testing. It involves a discussion of the risks of finding a mutation, what the risks of disease associated with mutations are, and how these risk estimates are derived and why they might be imperfect. A discussion of potential medical management implications and options, and I've told you these can be quite variable depending on the scenario and the gene. And then, importantly, the discussion of the familial implications of testing and the dissemination of information through the family and the potential need for familial testing. And then finally, the review of issues related to genetic discrimination. Now, what are some patient and provider concerns around germline testing that come up in the context of informed consent? Near the top of the list, of course, is genetic discrimination. We know that in most states in the US, There are laws against discrimination in health insurance, but for example, life insurance may not be covered in anti-discrimination laws. Another possibility is unwanted or non-actionable risk information, as we've discussed, having to do with multi-gene panels and multiple cancer risks associated with a single gene. A third area of concern are the uncertainties regarding the VUS that we've talked about that can create concern for both providers and patients, and sometimes inappropriate medical procedures done based on the assumption that a VUS is likely to be significant clinically, which, as we covered, is not likely to be the case. Of course, access issues for genetic testing are important because insurance coverage is variable for genetic testing. And finally, all the complex familial and social issues that come up regarding the identification of a mutation in the family, what the index patient would do about that information, and the impact on the family in terms of sharing, in terms of testing other family members, and in terms of the potential of transmitting the mutation and the cancer risk. What are some of the ethical challenges that we face as we deal with these informed consent and other issues as germline testing evolves? One is an issue of familial disclosures affecting clinical interpretation. So this is an example where, for example, a mother might have an early onset breast cancer. The mother's daughter is very concerned about her risk. Perhaps the daughter is found not to have a mutation. The daughter has had no cancer. But it's really the mother's genetic test which will tell us whether there is an informative genetic result that could help us interpret the daughter's test. There are cases where family members aren't willing to share that information because of familial guilt or other reasons, and this can create a challenge and sometimes challenges within the dynamic within the family. Related to this is the familial implication of test refusal in the same scenario. If the mother with the early onset cancer refused to be tested, that would have negative impact for our ability to interpret the daughter's test. Again, a challenge within the family. Another issue that comes up is the testing of minors for adult onset syndrome, such as BRCA1/2, where there are no specific clinical guidelines before adulthood, and yet minors which should be tested with parental consent needs to be a carefully considered issue and evaluated on a case-by-case basis. Another issue that's come up in the ethical scope is the scope of prenatal genetic selection, which is performed in some instances to eliminate the passing of a genetic mutation that confers cancer risk. So we might ask the question, what are the mutations which this would be an appropriate procedure for? Obviously, a topic for which much discussion, thorough consideration is required. So we've talked a lot about complexities, we've talked a lot about challenges, but I did want to close with a slide that reinforces how important germline testing can be and some of the progress that it's led to. So this is a slide from a recent clinical trial that was reported in the reference at the bottom for something called a PARP inhibitor used for BRCA mutant tumors of many kinds now. And this simply shows the dramatic increase in progression-free survival for patients with PARP inhibitor versus standard treatment in the post-treatment maintenance therapy setting for patients with epithelial ovarian cancer. So you can see the dramatic increase in progression-free survival that is shown by identifying the genetic mutation and prescribing the right therapy. So with that, I would like to close and thank you very much for your attention.
All right. Thank you so much for these excellent talks. I think we have a chat and several questions came in. I'll start with one that is, could you comment on the potential implications of germline testing on choices for therapies such as radiation for breast conservation? And I think that may be a question for you, Leif.
Yes, I think this is an area that is evolving as we generate more data. And this is clearly an area where the fact that more people are getting tested, where more folks with these hereditary mutations are being identified, allows us to refine our treatment recommendations. And the instance mentioned is actually a good one. I remember 20 years ago when I was an oncology fellow, and there was a big dispute in the literature about whether ATM mutations, which are relatively rare and few people were tested for them, have a potential increase in radiation complications, either therapeutic radiation or diagnostic radiation. But over the years, as more people have gotten tested, we've been able to accumulate a body of information. The general consensus now from all the accumulated data is that ATM in particular is not associated with substantial increases in toxicity from therapeutic radiation. And so this is an area where patients are able to get the most effective therapy when appropriate, despite a potential germline finding. So a positive story for more information coming from more people knowing about their germline history and mutations.
Thank you. Geoff, I thought it was fantastic. You mentioned that you're a genotyping enthusiast, and you outlined the need for continued improvements, right? Regarding reporting, regarding, genotype content. Would you mind explaining a little bit how this continuous improvement versus some lockdown that you have to do for regulatory approval can be balanced? Because that's an enormous challenge.
It's a great point. What kind of improvements? Improving the gene list, improving the chemistry of the test. These are kinds of things that are underway, and they're underway in coordination with regulators, where there is a very clear step to say, look, we've identified the opportunity to improve performance through this and that evolution. And yes, it requires that ongoing dialogue with regulators. And when you embark upon regulatory approval, you do it knowing that there is going to be that conversation ongoing. You have to be ready for that. And that's even actually trickier as you think about global regulators, just to be clear, right? And so, for example, we have tests that are now approved in Japan. There's a process embarking in Europe, and you can imagine the need to evolve each of these tests globally in some parallel process. And so, yeah, it's hard. It's worth it, I guess. There are other changes that can be evolved without the regulators. So, for example, the pathologist can improve the professional services page, the clarity of reporting, the content and the implications on its own without needing to check with the regulators. And so, for example, the recent addition of this germline banner to say, look, there might be a germline variant here, go get germline testing. This was done mostly out of the ethical implications that we feel it's important to be forthright about this. And that's not a change to the assay, it's just a change to how the pathologist interprets the results and presents them in a way that are usable. So I think there is room for improvement, and we're always looking for feedback on how to do it better, I guess.
Cool, thank you. It's an interesting segue to the next question, because Leif or Geoff both, I would want to hear from both of you, because I know you both have seen patients. There's a lot of additional administrative efforts. And I think, the consent is one element, and you outlined that beautifully about the, practical implications. But there's clinical decision support, there's cost estimates, there's prior authorization. Do you mind both commenting on how you foresee that will change? Because there's a lot of things that have to be navigated that are not technical and not related to the findings themselves. Leif, do you want to start?
Yes, absolutely. And I think that, I think as Geoff articulated so beautifully about how genomic tumor testing is becoming so valuable and a part of standard care, and the same is true to germline, particularly for cancer patients in regards to therapy. The idea that we need to lower the barriers, make the process more straightforward, both for providers and patients, I think is really critical. And it's an area which, we are working on very actively, as are a lot of centers, because, physicians in the clinic are ever busier. Oncologists, fortunately, have more choices in therapy that can be directed, but also that takes more time, more discussion, and then piling on different levels of complexity having to do with genomic testing and having to do with germline testing, really, as well as all the administrative, insurance, and other issues, really can be a big lift. So it's really incumbent upon us in the medical community to try to provide support, streamlining, and processes that all have an eye toward increasing access, facility, better communication with patients. And I think a great example of that actually is the test reporting. Where years ago, among the first labs that started doing the testing, it was really a big point of discussion about how this information could be communicated effectively, and that has evolved tremendously. And I'm hoping that the same will be true as we go forward with the entire testing process, both genomic tumor testing and germline testing, that it can be made more streamlined, more easy to provide better access and more useful and informative information.
Geoff, do you want to briefly comment?
I'd love to. And Leif, you use the word, I really think it is access, right? I think a lot of why I took this career move of my own was I didn't want NGS to be a thing that we could do at ivory tower academic centers. I really wanted this to be democratized. And I think, honestly, FDA approval of liquid biopsy is part of that. Really, any cancer patient can get NGS now. Now we have to make sure we help them interpret it. You're right, there are administrative challenges to that. How can we make it easy? So it's important to me that tumor profiling does not require patient consent. It doesn't. The physician needs to sign the order, and otherwise it should be orderable. There shouldn't be challenges to sending it off, okay? There can be paperwork, there could be prior auth, so that then requires that we, the lab, do that negotiation on our own. So with FDA approval comes CMS reimbursement. Medicare patients can now get NGS. No paperwork needed as long as they meet the criteria, right? Other negotiations with insurance companies can happen on the sort of on our side to ease the process then on the clinician. But there's all sorts of ways we can make it easier, right? How can we get the results easier in their delivery? Amazingly, people are still using fax machines. Like, we have to move to electronic portals if we want immediate access to these things. We have to find ways to integrate with EMRs. Currently, I think savvy academic centers have figured out how to do this, but a lot of community centers haven't worked this out. If we want to democratize access, we have to get omnipresent in folks' EMRs so that we can really make this accessible. And so I do think that opportunity is ahead of us. We see that need. It is possible. But you're right, we need to design our tests not just to be high quality, but to be accessible high quality so they really can be used by every oncologist and every patient.
Mm-hmm. There's a question from Salma Demir to you, Leif. So Dr. Ellisen, I wonder if the BRCA1 and BRCA2 mutations of good responder patients to olaparib have premature stop mutations or missense mutations. Is there any difference you noted personally?
Yeah, it's a very good question and an evolving area where we're able to see more variants and correlate them with responses. By and large, the mutations that are known to be clinically risk associated, be they missense mutations or be they truncating stop mutations, are generally associated with significant responses to PARP inhibitors, and there has not been clearly a difference per se between mutations that are clinically meaningful, that are missense versus nonsense. However, there are differences related to BRCA1 versus BRCA2, and one of the most interesting stories that's been evolving over the last decade or so has to do with the issue of reversion mutations. And it turns out that some BRCA mutations are more easier to revert. That is, somatically, the tumor can splice out or change the deleterious mutation to thereby reconstruct a functional protein and thereby induce acquired resistance to PARP inhibitors as well as potentially to chemotherapies that target the BRCA pathway. So there are indeed some differences that has to do with the ability to revert. So for example, a mutation where an entire exon is deleted is far less likely to be able to be reverted by the tumor to induce acquired resistance than a single nucleotide change. And that definitely can make a difference in the clinical behavior and the response to these therapies.
It's a perfect point, especially given, multiple therapeutic choices. Geoff, do you want to comment on the importance of next-gen sequencing in patients that develop resistance, like we've just outlined?
Right, PARP resistance, AR resistance. If you have AR resistance, don't pick another hormonal therapy, switch to chemotherapy, right? Certainly EGFR and ALK resistance in lung cancer, where there are trials and established therapies targeting many of those. I do think a clinician should aim to know what they're looking for, what they're going to do with it, all right? And that, the literature is still evolving, I think. In colon cancer, where RAS resistance says you can stop an EGFR antibody and then restart if that resistant clone has evolved. And so, no question, there's a moment there to extend someone's benefit from precision approaches through retesting and finding precision adaptations rather than needing to reach for chemotherapy. A lot of my lung cancer patients are chemo reluctant after a couple of years. They want to extend the benefit, and we can sometimes do that combining therapies and being innovative through retesting, often with a liquid biopsy and tissue as backup.
Perfect. Leif, another question regarding germline. Angel Guerrero asked, in somatic testing, when should a finding in a gene associated with susceptibility or a hereditary syndrome should trigger a germline test or germline testing?
Well, this is a great question for Geoff to weigh in as well, but and also for you, Dr. Lennnerz, because in essence, part of that is an analytical call having to do with what you read in terms of the sequences and whether it appears based on the sequences that you're reading. As Geoff mentioned, massively parallel next generation sequencing, you're sequencing many, many times. You can actually look at the proportion of the mutation in the sample, and often that will give a clue as to whether it's likely to be a germline variant. Alternatively, there are certain types of mutations, namely that are known as founder mutations that are common within a population. If you see a founder mutation, that a priori is often more likely to be a germline, but it definitely requires expertise and interpretation by the laboratory, by the pathologists to try to assess this. That being said, it's not always going to be a perfect assessment. And you can imagine that labs might have an interest in being sure that they're not missing potential germline calls to saying that, well, we think it could be, we can't be certain, but this is an indication for the patient to pursue germline testing. And generally, that's the wisest course, is you want to be sure you don't miss those, not necessarily that you need to call everyone correctly.
Geoff, what do you think?
Yeah.
Testing germline for everyone?
I mean, for BRCAs, there's more and more literature that says, yes, these deserve follow-on germline testing, because the fact is that, right, Leif, access to germline testing is not widespread. There are a lot of patients who are not getting the testing they should have. We should use somatic testing as a lead-in. The cutoff we make is at biological plausibility. So if in a tumor specimen the VAF is less than 10%, we found that not to be biologically plausible. Or if in a liquid specimen it's less than 30% VAF, if it's not biologically plausible, we don't emphasize that possibility. But if it's within the range of plausibility, I think it's appropriate to consider that testing, and that depends upon the patient. The catch, I guess, would be genes like P53, where the pretest probability is so low and the likelihood of it being somatic is so high that I don't want to lead to the sort of, there are a lot of pseudo-Leif Raumanis out there emerging, right, that aren't really syndromic and are just VUSs. And so that's a gene that we don't articulate this need, but certainly for BRCA and others. And we're always evolving that list of genes. And ATM and CHEK2, as you've pointed out, are now being seen as more actionable, and we've elevated those as genes that we want to articulate that risk more clearly, and that requires evolution. Dr. Lennnerz, how do you consider this in your own lab, I guess?
It's tough. You know, there are many, many constraints. Of course, knowing germline would be fantastic, right? Knowing the germline status of patients would be amazing. But, you know, general germline testing comes with a lot of additional effort. You know, probably our genetic counselors would have to at least double or triple because there's so much more that we would find. And then obviously there's financial constraints, right? To make sure that every patient would get the best test. I believe in, you know, the next couple of years, we would probably all argue you need to have a germline test once. You don't need to repeat it because you have a basis. When you think of some of the hematologic malignancies or liquid biopsy, we can drill much deeper into, you know, our understanding for what you call biological plausibility if we had that. What do you consider sort of the best way to report this? Because ultimately, if we have germline and somatic, right, both reports collide. Leif, do you see that in your practice, or when you have, you know, a result coming back on BRCA and it's present somatic and germline?
You mean in the setting of tumor testing, or?
Yeah.
Mm-hmm. Yeah. Well, I think that you know, again, part of it has to do with the clinical data, and we do believe that in most circumstances, that in terms of clinical actionability from a therapeutic standpoint, the two may be equivalent in many circumstances. In contrast, of course, in regard to risk of other cancers and familial risk, they're completely distinct. So one has to make that clear distinction between the actionability for the tumor, where a somatic or a germline event could be similarly actionable, as opposed to the germline, which, you know, knowing that for risk of other cancers and familial risk.
Yeah, and we just report them all. Per the label, the test doesn't distinguish tumor or germline. We're going to give you the results. And I think there are other approaches, which is to actually hide the germline findings. I don't think that's the forthright way. I think the ethical approach is to provide the results because it's part of the testing, and the germline suspicion is incidental and has to be discussed with the patient and physician. But I'd rather give the results out there forthrightly than try to bury certain results because it's better left unsaid. I don't think that's the way of the future.
Perfect. Thanks for the discussion, Dr. Oxnard, Dr. Ellisen. Fantastic. I hand it over to Dr. Chapner now for the closing remarks. Thanks a lot.
I hope you can see me. I'm actually doing this through my iPhone. I've really enjoyed this presentation. Joe, thank you for moderating. Geoff and Leif for very interesting and useful presentations. I would just emphasize a couple things. One is that despite all the progress, not all patients who are really clearly candidates for NGS testing are actually being tested. For example, recent studies in non-small cell lung cancer patients who are obvious candidates showed that about 1/3 of those are not being tested. Secondly, we should emphasize how important all this is to clinical trials, to patient selection, to understanding drug response and resistance. And so this has just totally revolutionized the way we take care of patients. And there's a lot to understand for the practicing clinician, but it's an extremely valuable development in cancer treatment. Thank you guys so much for your very informative presentations.